Imagine you are walking into your morning clinical rotation at the hospital, and you're looking at your patient assignment. You see a 78-year-old patient who is noted to be confused. If you just shrug and write down dementia in your care plan, well, you are missing the entire clinical picture. We as nurses have to do better than that. Dementia is not just one thing. It's this broad umbrella syndrome of cognitive decline, but the underlying cause changes everything about how we care for them. Think about it this way. Most of the time, about 60 to 80% of cases, we're talking about Alzheimer's disease. It's chronic, it's insidious, starting with subtle memory lapses and progressing over years. But then you have vascular dementia. That's a completely different beast. It's caused by vascular disease, where the vessels deep in the brain stiffen, cutting off vital blood flow. So instead of a slow, steady decline, vascular dementia often hits abruptly or moves in a stepwise pattern. One day they are stable, then boom, another tiny silent stroke, and they drop to a new lower level of function. And then there's frontotemporal dementia. This one it's actually quite tragic because it strikes earlier, often before age 60. It attacks the frontal and temporal lobes, meaning you don't necessarily see memory loss first. Instead, you see massive, sudden personality changes, loss of social inhibitions, or language struggles. But the one I really want to hammer home for your exams, and honestly for your safety at the bedside, is Lewy body dementia. It makes up about 10% of cases, and it is incredibly unique. What's happening is these abnormal deposits of a protein called alpha-synuclein, we call them Lewy bodies, they physically block the communication between neurons. If you look at a brain autopsy of someone with Lewy body, you see these pink circular inclusions inside the brain cells. Because of where these deposits form, these patients present with a wild mix of cognitive decline and Parkinsonian motor features. I'm talking about muscle rigidity, a shuffling gait, and tremors. They also experience vivid, often terrifying visual hallucinations and extreme fluctuations in alertness. 1 hour they are completely with you, and the next they are deeply lethargic and disoriented. If you give a Lewy body patient standard antipsychotic medications to control those hallucinations, you can actually cause a life-threatening reaction. That's why accurate diagnosis is everything. So how do we assess this? Well, in clinicals, you'll use tools like the Mini Mental State Examination, the MMSE, or the Quick Mini-Cog. We're testing executive function, orientation, attention. But here's the major clinical trap you will face as a nurse: separating dementia from depression. Older adults with depression are so often misdiagnosed as having dementia, and vice versa. We call this pseudodementia. When you test a depressed patient, they might just shrug and say, "I don't know," because they lack the energy or motivation. A patient with true dementia will usually try, but they'll get the answers wrong, or they'll try to cover it up, what we call confabulation. You have to look closely. Is it a cognitive deficit, or is it a treatable mood disorder? Never assume. Now, when we look at Alzheimer's specifically, we are talking about a physical dismantling of the brain's architecture. On a cellular level, you've got two culprits: beta amyloid plaques forming on the outside of the neurons, which triggers this massive inflammatory response, and neurofibrillary tangles of misshapen tau proteins inside the cells, destroying the transport system. The brain literally shrinks, connections are lost, and neurons die. By the time you see the clinical symptoms, this pathology has been quietly building in the brain for 15 years or more. As the disease progresses to the moderate and severe stages, the nursing care becomes highly intensive. You're no longer just dealing with forgetfulness. You're managing sundowning, where the patient becomes highly agitated, confused, and combative in the late afternoon or evening. You're managing wandering, which is a massive safety hazard. If they are pacing the hallways, they aren't doing it to annoy you. They might be searching for something, or they have a full bladder and can't find the restroom. Our intervention? Don't argue. Do not try to orient them to 2024 if they think they are 20 years old. Redirection, distraction, keeping a quiet, low stimulation environment, and giving simple, one-step instructions. That is how you maintain their dignity. But let's draw a massive, bright red line between dementia and delirium. This is classic NCLEX material, but more importantly, it is a life or death clinical skill. Dementia is chronic and progressive. Delirium is an acute medical emergency. It is a state of severe confusion that develops suddenly over hours or days. If your normally sweet, oriented 80-year-old patient suddenly starts screaming and trying to climb out of bed, that is not dementia. That is delirium until proven otherwise. And it is almost always caused by an underlying physiological trigger: hypoxia, electrolyte imbalances, a bad drug interaction, or the classic one we see constantly in older adults, a urinary tract infection. A UTI can make an older adult look completely psychotic, but if you treat the infection, the delirium resolves. Another situation that often leads to delirium is simply being in the ICU setting. Aside from the physical illness the patient is experiencing, they are experiencing constant beeping noises and suffer from sleep deprivation. This alone can cause delirium. To catch this at the bedside, you need to use the CAM, the Confusion Assessment Method. You're looking for an acute onset, a fluctuating course, inattention, and disorganized thinking. If they meet those criteria, you have to act fast to find the cause, because delirium is highly toxic to the aging brain. And please, remember, non-pharmacological interventions are your absolute first line of defense. Keep their glasses on them, make sure their hearing aids are in, put a calendar on the wall, and have a family member or a safety partner at the bedside. We only use medications like low-dose antipsychotics or Precedex as an absolute last resort if they are a danger to themselves or others. And let's not forget the caregivers. The physical and emotional toll on families caring for someone with moderate to severe dementia is overwhelming. Caregiver burnout is real, and it leads to elder abuse, health crises for the caregiver, and family breakdown. When you are assessing your patient, you are assessing the family too. Teach them about adult daycare, respite resources, and help them establish a routine. All right, next time you head into the clinical setting, keep your eyes open for those subtle cognitive shifts and make a positive difference.